not the criteria against which we should really judge ministers and ministries. What's a hospital is really a factory. It's a factory that produces curative health services, and it has to be taken as such. If it is a factory and it is not the primary responsibility of the Ministry of Health, what would be the responsibility of the ministry then? Versus, because you hear a lot, I'm coming now to the context of Libya, where the minister has been, every minister there have been two so far after the revolution, have been negged against hospitals working or not working, people dying or not on hospitals. The minister and the ministry should be responsible for the conceptual framework, for the standard setting, for the control and the inspection of the work of the hospitals, but for the regulation functions, but not for the direct management of hospitals. Definitely, that one doesn't belong to the ministry itself. The latter, which is the direct management of the hospitals, should be delegated to much more peripheral level, meaning to the local authorities and to the local council in an ideal world, but we are not yet there for the time being in these countries, nor in the neighboring countries as well. What are the management parameters? I'm saying all of these because you cannot just think about a chart of a hospital or a model chart without taking into consideration all these parameters. If they are, again, a care service factories, their services, as I said before, are priceless, but they have a cost. And therefore, that cost needs to be controlled. Service standards and qualities are of the utmost importance. They need to be defined. What are the standards? What the quality control? Implemented, monitored, and controlled on a continuous basis if a hospital is to succeed. Appropriate level of human and financial resources should be dedicated. You have heard about numbers. But what we didn't hear about today is about norms. Someone after these numbers came up and said, but in an intensive care unit, you will need 6 nurses per bed. It's true. But if you go to dermatology, you need less than 1. So where are the norms here that would be applied to all hospitals, regardless where they are situated? In some places, you will not reach these norms, but you will tend to reach them. In other places, you have much more, but you will tend to decrease them. And this is the way it should be managed on a longer-term basis. Being a sophisticated factory, when I say it is a factory, it is as if it is nothing, it's a factory, but it is a very sophisticated. You think about a hospital, and nothing that happens in a village or in a town that doesn't happen in that hospital, from food to cleaning to electricity to everything you can think about will happen in that hospital. So it is sophisticated. Being such sophisticated issue, it is not, we think that doctors will make or break the reputation of that hospital. That is, again, is a myth. It is not true. There are several functions that one need to cater for when you reach a hospital. Management and managers, the quality of managers, and my predecessor have gone thoroughly into that. It matters a lot because these are the leaders. Medical and nursing services are in the heart of the hospital. The reputation of the hospital will be on that one. But think about it. Doctors cannot work in a vacuum. You can bring the best doctor you can think about. If the services within the hospital and the environment of work is poor, that doctor or that nurse will not be able to perform. Then the hotel services, accommodation, food, security, water, electricity. Take one of these out and the services will break down. Paramedical services such as biomedical engineering, gases are very important, and they are sometimes a factory on their own. Financial services, they are key. If you need something to buy and you don't have the resources, Or if you buy and you cannot recover, in a very short time, you will have no resources to function and you will be begging for additional resources that you will not get. Training, sorry, that's not a train, it's a training and education of the new generation, because most of the hospitals are also university hospitals or not even nursing hospitals where you need to train and educate the new generations for their functions. The chart, coming back to the chart because that's the subject assigned to me, should cater for all what we have mentioned. It doesn't cater only from the patient until it gets out. It's all the services. So we cannot talk about chart without putting the questions, and these questions are for the new generations of the health in Libya. Who is the reference authority for the hospital? Is it MOH? I doubt it. If you keep MOH, the MOH will not be doing health. One of the yesterday speakers say, should it be called Ministry of Health or Ministry of Disease? If you keep the hospitals alone, you will need to change the Ministry of Health into Ministry of Disease. Second, the profile of the top manager. Is it a doctor to be heading hospitals, or is it an administrator? Or is it somewhere in between? I will go for the somewhere in between. If you go for a doctor, that doctor should be trained and qualified in management. If you go for an administrator, that administrator should be trained and qualified in public health and patient safety. But it cannot be this or that. You need to go into the best qualified in this structure management. Priority of medical and nursing services versus the other departments. I agree that medical and nursing services are of a paramount importance. That's what makes and breaks the reputation of the hospital. But it cannot work if, besides that, you have no security. Besides that, you will have interruption of the gas. Besides that, the IRM will not function and the laboratory will not be working because the biomedical engineer is not qualified enough to maintain the machinery that is in it. What's the cost? We said it has no price. But what's the cost? Where are the norms for the cost? Can I know when I get into a hospital how much I am going to pay? Who is paying for me? How the hospital will recover the cost? If you think that you dump the money into the hospital, which is happening right now, and once that money is spent, you call for another money, that is not something to do. Each service you are providing has a cost. If it is a cost and it is a factory, that cost has to be recovered. And the system should be there in order to recover these costs on the proper time so that you don't fall in a situation where you have no money. How far could we make the hospital independent? In an ideal world, a factory is not managed by the Minister of Industry. A hospital is not managed by the Minister of Health. The management is delegated to the peripheral level where the hospital is serving, meaning to the community level, meaning to the local council. The minister, whereby I say the minister, meaning the ministry, is responsible for putting all the conditions for that hospital to work wherever it is, to control, to put the standards, and to be able to take over if there is a big failure. Now to the chart. That's the final thing. This is not a chart that you can take and apply to any hospital. But having said what I said, if you tell me what would be the model chart that you will put together, there are a number of variations to this one. But what I would like to say that the local authority council should be on the top of it. They are the ones to decide the level of health services they want to give to their community And therefore, they have to be accountable to their community on the level of their services. But in order to be accountable, you need to put together a team that will oversee the service of this hospital, and that is the Hospital Administrative Committee. Hospital Administrative Committee is the one to select the CEO according to the criteria and parameters and the standards put by the Ministry of Health. And then the CEO, in performing its duty under these and according to the Ministry of Health standards, will have to have two very important bodies to help him delivering. The first one is the Medical and Scientific Committee, which has a very important role in deciding about what breaks, we said, and puts the reputation of the hospital. The head of this one should be part of the Hospital Administrative Committee, so there is a voice that goes from here to this one. And the quality control and internal oversight services, what we call before audit, because that one will look into whatever is going in terms of expenditure and recovery, evaluation, continuous evaluation and monitoring of the services. The departments here, these are the minimum number you can have. The medical services, the nursing services. See that there are two departments on an equal foot. Medical services and nursing services are equal. They are not subordinate to each other. Many people will think the contrary, but I would maintain that this is the case because the nursing services today have equal responsibility to the medical services in making the patient safety. The admin and finance, recovery of the money and what have you, the building and the common services which cater for all the other activities. This is the minimum. In some of the countries, they will add biomedical engineering. They will add additional functions. There is no limit to it. But if you keep the list short, the management will be easier. If you make it big, it will be an inflation of titles and less control. Pyramidal approach will suggest that under each one of these, there are a number of functions that you can add. So this is only a template. What is more important of this is not that this part, the blue part, it is this part and the role of the Ministry of Health in setting standards and norms for the hospitals to function. That is much more important for me than this part, which can vary a lot, actually, from one structure to another. One final say. If you implement this here, you implement it in Zambia, and you implement it in Kuwait, it will have different cost. The health services are commensurate to what the community could afford according to each social status. So this could function under any environment. But then you put the level of the health services to the level of what the community can afford. And if you put it at the level of the council here, believe me, the council will look at it 3 or 4 times before they deliver a certificate for someone to go and get it treated for free, while he or she has to pay a little amount in order to go for that treatment. That's why the responsibility at this level is so important, and it discharges the Ministry of Health in order to do what the ancient Chinese families were doing, keep the population healthy and productive. Thank you.
Thank you very much, Dr. bin Yahmed. And please, Dr. Oin again, please. We have the hospital versus center based services. This is the last presentation for today. Thank you.
Thank you very much. now to be giving the last talk of the very long day that we've all had. So thank you very much for that opportunity. It's called Hospitals versus Health Centres. I wasn't quite sure how that fitted with hospital management, but I remember going to Tripoli Medical Centre in 2006. I remember going to Benghazi Medical Centre, which very sadly was empty, but I went there in 2006. I went to Tobruk in 2006. I must say that was the best hospital I went to, but I may cause a problem by saying that. And I came back again and went to Tripoli Medical Centre in March of this year. And I heard again the big problems that the hospitals face. And we've just heard some ways of trying to tackle those problems and the leadership that it needs. I think Randall's talk was brilliant about health leadership. I've been a chief executive in the NHS for 20 years, so I have a lot of respect for that analysis of what makes a good leader. But as well as the problems inside the hospitals, they all complained about primary care and said the problem was primary care, that there wasn't enough service in the community in primary care. And I suppose one of the answers to hospital management is if no one else is developing primary care, maybe you'll have to do it yourself. So I'm afraid I took the title to mean that, that I needed to look at whether primary care was worth doing. In the UK, I think we spend, it depends how you measure it, but we spend about 50% of our budget on hospitals and about 50% on everything else, so primary care, community, mental health, ambulances, and so on. We're trying to make it less on hospitals. It's coming down 50%, 49%, 48%. That's the intention. We want more to be invested in community care because 90% of care and treatment happens in community and primary care, only 10% in hospitals. So looking at what a health centre might be, and there's nothing to stop a hospital developing a health centre inside the hospital. We've done that in some places. It works quite well because patients come to the hospital, they know it's there, it's big, they see it, they come. So why not have a health centre at the front door so they get primary care at the front door of the hospital? That's one option. So hospitals shouldn't feel it's someone over there that develops primary care. You can do it in the front door of your own hospital. You won't be able to do that everywhere. You will need health centres. And of course, we've heard a lot today about how primary care has to be more than just GPs and family physicians. It has to be about health and well-being, diagnostics, and also visiting specialists coming in, and indeed a place for clinical education. But I'm going to focus on primary care. We had an earlier Finnish speaker talking about what it was, and that's exactly what she said, so I'm quoting the same thing. It's about where most of the care, the assessment, the coordination goes on. It's where the real continuity of care for all patients happens. And of course, it's not just about doctors, it's not just about nurses, it's about a whole team. And I think increasingly, if you talk to any GP in the UK now, their experience has been, isn't it fantastic to be able to rely so much more on people like nurses looking after most of our patients with long-term conditions, for example. So a much bigger team than just the doctor, much bigger team than just the nurse, and of course around that, more and more using the services of psychologists, of midwives, of therapists, pharmacists and dentists being part of that wider team, either coming into the centre or linking with it. Now, we've talked a lot too about the pathways, and I won't go on about this, we've talked about it. But again, if you're going to have most of your care, but also most of your prevention done in the community, in primary care, they need to be part of the pathway and the staff need to be there. And if they need to be referred into the hospital, then that's fine, but it needs to be a careful gateway through which the patient goes. And also a good way of bringing the patient back. When I went to the primary health centres in Tripoli when I was here 6 years ago, one of the things they said was the problem was not getting information back to them about a patient who'd been to hospital. Now, if you're going to look after the patient, you've got to have the systems so that not only is the referral made properly, but the discharge is made properly too. But you're also referring and need to be able to refer to a much wider range of community services. And I think what we've been hearing is that primary care needs to have access to a range of services, mental health services, for example, family planning, crisis response, rehabilitation, if it's going to be able to coordinate and look after all the patient's needs. and the same in diabetes. I mean, my aim would be for almost no patients ever to go to hospital with diabetes. You could argue that it's a failure for a diabetic patient to end up in hospital. I'm sure, of course, I know there are exceptions to that, but the aim should be to treat every patient with a long-term condition outside of hospital, and that's really what this pathway is saying, and I won't at this late stage of the day go into the detail of that. Now, does it work? Again, I think we've had some references to that today. It does work to have primary care. I mean, even in this, well, say even, in the United States, where there's a less integrated system, the research has shown that if primary care is the first place you go to and your regular source of care, you will have low utilization of hospitals but better outcomes, and lower costs, obviously, with low utilization. And similarly, I was amazed by this finding that regular primary care will actually lead to lower mortality rates. So it's about over-intervention if you only have a specialist system. And internationally, again, we've heard from colleagues from the World Health Organization and otherwise that a system with primary care in it will lead to better outcomes and lower costs. So we know it works. And this is maybe controversial, this one. A recent study of 17 Western countries' efficiency and effectiveness showed that the UK's experience was right in pursuing primary care as a universally accessible service for all patients, and it was cost effective to invest in primary care. And also, the experience has been that it reduces inequality. Now, I sense in Libya that equality of access, equality of experience of healthcare is absolutely crucial to you. Tell me if I'm wrong, but that's what I've picked up. And certainly what systems with primary care in it will be a fairer system, will tend to make sure that people in deprived areas who often have poorer health will get a good service and will get good access to service. Now, it's not any old primary care, just shoving a few family medicine doctors into a centre does not make it work. These are the conditions which have been, it's said, primary care works best with. So you have to make sure everyone can get to it, and it's easy to use. It needs to be really 24 hours. You might have different systems out of hours, but it needs to be there for people. So mornings only, which we're hearing is how it's operating at the moment in a lot of places here, will not be enough. And also, if you ask people to pay a lot of money to go to primary care, they're not going to go, and it won't work. So a variety of things, and we've heard today a lot about guidelines, about good, well-trained staff, about a range of services being available, and a proper performance framework, a quality framework to ensure that primary care is working correctly is absolutely critical. And of course, we will have to develop, and we have developed in the UK now, electronic systems so that not only the GP knows what's happening, but the whole team know what's happening to the patient, and they can refer good information to the hospital, and the hospital can refer good information back, and they're getting it quickly. They're getting the results of diagnostic tests and so on electronically. Now, I'm not to say what you need, but this is what we're hearing, that it's about providing a much more effective system of treatment and care outside of hospitals. So the hospitals will never be able to be managed properly unless there's a primary care system working in this way, improving access, continuity of care, health promotion and disease prevention. And that, I suspect, as we know, as we've heard today, needs an expansion of the staffing of the primary care professionals. And also a system that says you can't go to hospital unless you've seen your GP first, at least for planned care and preferably for emergency care as well. Now, we've got a lot of things we'd be very interested and excited to share with you if you found that helpful. And I know some colleagues are already doing that from the Royal Colleges and from other places, but we've got a health protection agency that's very keen to work with other countries on health promotion, disease prevention systems. We've got a lot of experience in seeing how the whole system can work best together. We'd be very interested in working with pilots of primary healthcare centres to work them in a new way. We've got people who've got a lot of experience with getting the right guidelines, getting the patient going through the right pathway. and managing the medicines for them in the correct way. Huge amount of training, as I've said earlier, training providers, especially the Royal Colleges and universities, and indeed information system suppliers who can come and talk about case management systems. Now, we also have, as I think we heard earlier under the PPP discussion, a range of companies and organizations that would be very interested in working as partners with you. But as my colleague Andrew Valenzuela said earlier, we're not here to sell anything. We really are genuinely concerned to work with you and support you, because it is a fantastic opportunity. It feels sometimes daunting, I can tell, for Libya to become this brand new health system, which it will do. But we're very excited to work with you, and in the way we can help, we'd like to do. And in the meantime, we wish you the very best of luck and hope that that you will have a lot of support from within the country and also from all your friends around the world who see what a fantastic job you've done so far. So thank you very much.
Thank you, Mr. Bone. Actually, the name was listed in the schedule was Mr. Owen, but it was by mistake. So we apologize for not mentioning your name correctly. Just we can open the floor for some questions. We just want to remind you with the three presentations. First one was by Dr. Williams about the leadership quality of the hospital managers and the elements which make the leadership effective. And the second one was about the name of by Dr. Ben Ahmed. It was about the organizational chart of hospitals, and he mentioned the MOH duties and the management parameters for the services, and also what is the role of the MOH, and the last presentation by Mr. Bourne about the primary health care and its primary health care as a gateway to the hospital care. And you can ask questions for the presenters. Any question? Everybody is tired, I think.
Regarding our last title, Dr. Pone, what the steering committee was thinking is the hospital care versus the specialized centers care. Means that grouping like renal diseases, renal transplant in one center, or putting it inside the hospital, and similarly other, like we have the diabetic center separately, or you incorporate this in the hospital. That's what they meant.
Right. Thank you. I mean, just to respond to that, I mean, I think clinicians in the UK find it very useful to be grouped together. That for two reasons, really. One is because there's so many comorbidities now, particularly for our population, which is an aging population. Patients have a lot of different needs all together in one patient. So I think for that reason, and because there's a lot of overlap in the skills that are needed, but also in all the support services, the diagnostics, for example, that actually they, on the whole, would argue for bringing things together into one place. It's more efficient, and patients get access to a wider range of skills for their additional problems. So I think we've seen, for example, we used to have a lot of orthopedic centres. They've now come and joined the general hospital and become part of bigger hospitals. So in the main, for the more specialist or for the particular specialism, we would say bring them together into one place. That's been our experience. It may be different here.
Thank you.
Microphone. That's right.
I have a small question. People in Libyan hospitals, they fight for to be a managers, and you will find divisions in hospitals because of this fighting. Is the situation the same in UK?
Yes, I think so. I think people find that the work is always a mixture of the strategic planning and the thinking of great thoughts and the vision and the values and developing the quality of care of the hospital versus the day-to-day pressures. And I think any manager, and I think again Randall expressed this, that any manager has to be able to be strong to cope with the day-to-day pressures, which are firefighting, but also keep time for strategic thinking. So it's a question of having the skills and the courage and the strength to build in time for strategic thinking and getting the team to work well on the future, even while there's a lot of business and a lot of pressure and a lot of problem going on day to day. And it's about having the right team around you as well, making sure you've got a team of people who can deal with the problems so that you can do the thinking, to free you up to do the thinking and the taking things for the longer term. Yes, of course, any hospital is going to be a hot place. So you have to be able to manage that. But if you only concentrate on that, you'll end up going down the wrong alley, the wrong path.
I just want to connect the other two presentations of Dr. Yahmed and Dr. Williams. Dr. Yahmed said that the criteria of the managers or the CEO of the hospital should be listed by or should be mentioned by the MOH, while the leadership qualities, they are intangible to be put in criteria because they are not easily tested, because these are soft skills, and soft skills are different from hard skills. One can be tested before you recruit the manager, and the other, you should try him first to know that he has the leadership qualities. And that is a core problem, to have the right person from the initial or from beginning. Thank you.
Okay, finally, we would like to thank all our distinguished speakers today who delivered every single topic we planned for. And more importantly, to thank you all our delegates who have been very patient and attended to the last minute. It is amazing that you are still here with us at 8:30, even 2 hours after the planned program. Thank you very much, and we meet you tomorrow morning at 8:30.